Hi everyone. Now we reach the half-time of the second day of the International Aesthetic Masters and we travel to the Middle East, to the United Arab Emirates. I'm happy to present Dr. Anas Aloum, one of the most renowned aesthetic dentists in this region. Anas got his dental degree at the Jordan University in Amman and then an advanced certificate in prosthodontics from the Herman Ostrow School of Dentistry, University of Southern California, Los Angeles. He continued his education in the United States and got a certificate of preceptorship in periodontology and implantology given by the same university. Nowadays, Anas has a full-time practice at ICMA Medical Center in Abu Dhabi, focusing in oral rehabilitation and aesthetics. He's an American board certified prosthodontist and a fellow of the American College of Prosthodontics, and has been lecturing around the world about this thematic and about also implantology. Dr. Aloum will present today a lecture entitled From Planning to Execution, a success story in full arch implant restorations from start to finish. For those that are more into implant rehabilitation and implant dentistry, this is one lecture you shouldn't miss. Have fun!
Hello, everyone. My name is Anas Aloum, and I am going to be talking to you for the next hour from Abu Dhabi. It's sunny here. The weather is beautiful now in December, and I'm in the practice now, and I am actually recording this webinar during my working hours in my practice. And I'm very excited for the next hour to share with you my take on digital dentistry. I will be talking about how I see digital dentistry, the workflow on everyday practice from start to finish. My webinar will be will be segmented into two parts. The first part will be about teeth, and the second part will be about implants. And I think teeth and implants they act differently when it comes to digital, and teeth are a bit more forgiving when it comes to the digital workflow rather than implants. So, as I said, I'm a private practitioner. I work 5 to 6 days a week. I'm a prosthodontist. This is where I graduated from. I graduated from USC, University of Southern California, under my mentor Winston Chi and George Cho. And then I went back to Abu Dhabi. I did pros and I did implants, and then I worked as a lab technician in Los Angeles for a little bit, for less than a year, and then I came back to Abu Dhabi. And that's where I work with my dad. We are about 65 staff members at Hikma. And just to give you a little bit of history, 34 years ago, my dad started the practice. And the dental clinic was in our house. So basically the waiting room was our dining room, or our place where we spend our evening. And that's me and my dad. And at that time they didn't wear gloves. It's normal. And I used to love to polish, and I still do love to polish until now. So we worked together, we started together, and then we are now working together every day in, day out. We fight sometimes, but we're still pretty good. We're a very big team, specialists and lab technicians. And this is just a little photos of where I work at Hikma in Abu Dhabi. So I'll be talking about, as I told you before, the digital workflow. And the way I see the digital workflow from my trials, from the hundreds and hundreds of cases that we did, from we tried everything, every single thing that is probably in the market, and I can design it. I can divide it into two main parts. The first part is the designing and the treatment planning part when it comes to the workflow, and the second part is the restorative and execution part. And what I mean designing and treatment planning, I mean when we see the case, we start designing the case, we take our impressions, we take our photos, and we start to plan. Now, we didn't execute anything until now. We're still planning, and that's where you do your wax up to know where you are heading. If you're going for crown lengthening, or if you're going for implants, or ortho, etc. So the first part is the product of the first part is the mock-up. The designing phase, the main product of the first part is the mock-up. The second part, which is restorative and execution, is actually where you mill, or where you print, or where you make your final ceramic restorations, implants or teeth. The third part I want to talk about is the materials, and that's when we talk about digital workflow, we talk about monolithic materials, and I'm going to go into that because this is a very dear subject to my heart. Materials and the way we evolved through less layering. That's how I would say it. Anyway, so the designing and treatment planning is where we start to study the case and where we have very, very defined phases in the designing phase. And the most important phase, the most important step is to align the face with the model. That's the core element of the designing and treatment planning digital workflow, is aligning the face with the model, knowing where does the model stay in space. Is it tilted? Is it not? Is it straight? Because that might change your treatment plan tremendously. That might change. You might end up extracting teeth just because you've aligned the face properly. You might end up doing crown lengthening in the wrong place just because you didn't align it properly. So that's where we start to understand and design the case, and then we start to measure. And that's when we start to measure, saying I need to raise up or bring down or move, and you do your wax up. Now, the main element or the main product is the mock-up. That's the most important product of the designing and the treatment planning phase. The mock-up, or as we call it, the wax-up. Now, the mock-up is basically the product of the wax-up. It's test driving the wax-up in the mouth, and that's the mock-up. So the mock-up, or in the digital workflow, we have done a virtual wax-up. The virtual wax-up, we start to see where we are in the designing phase and start to understand our case. Now, the aligning phase, and as I mentioned before, is one of the most important steps in the designing phase. The aligning phase, we basically take very simple and precise photos, and there are a set of 2 photos only. We've got the smile photo showing the eyes, and we've got the retracted photo showing the eyes. That's it. These are the 2 main photos from the aligning phase. There is a very specific way to do them. And we are when I teach my the dentists that work with me here, or if I do any other courses outside, I'm very, very precise about how the photos are taken, because that might change the whole design phase if the photos are taken in the wrong way. Now, once the photos are taken, then we start to align those photos with the model and start to design the case. The designing phase is very subjective. Every person might design the case in a totally different way than the next person, because it's a very subjective, it's very artistic. You know, we try to go by the parameters of aesthetics, but still there is a little bit of difference between me and the next person who's going to design the case. But that's fine. And then we need to test drive it. We need to see how it looks, and that's the mock-up. That's the mock-up. The mock-up is basically when we try it in the patient's mouth and see how it looks. So when I talk about the two photos, and I'm very specific about these two photos, we should take the photo must be perpendicular to the face, and the photo must be hitting straight to the patient's nose or to the patient's teeth. That is very important, and the photo must show even sides from the right and the left side. So you're not taking it from the right or from the left side, it's straight to the patient's face, perpendicular to the patient's nose and teeth. This little video is showing you how the technician here is taking this intraoral scan of a case, and he's just viewing it now, and he's going to put the photo of the patient's face. The photo of the patient's face must coincide with the model, or the model must coincide with the photo's face, with the photo of the face. So you notice here that the technician is aligning the eyes, making sure that the two pupils are on the same line. He basically will choose common points. So here, as you can see, the technician is choosing the distal point of the central incisor, and is using the mesial point of the canine, or the mesial touch between the canine and the lateral. This point is chosen on the model, on the stone model or the intraoral scan, and they overlap. Once they overlap, that's it. The aligning face is done. We align the smile photo, we align the retracted photo, and after that we have a real view of the model in the patient's frame. The next step is trying to design the case. And you notice here that the technician is removing this transparent wax, putting the wax back. And that's the beauty of the digital workflow, that you can see your wax, you can remove your wax, you can take one tooth out and put it back in, and you can see where you are in space. There's no guesswork. And that's very different from the regular wax up that we do. This is the mock-up. What happens after we do the design, we produce the print, or the printed model, and that's the wax up. That's the wax up model. Just a second, I don't know what happened here. So you notice here that the printed model is being basically, it comes out of the machine, and the print is the mock-up, is the wax-up, is a virtual wax-up. It's a plastic model that just looks just like the wax-up that we have done digitally. Now, the beauty of this virtual wax-up is that we can always view our wax-up and look at it from different angles, and we can use the option of having it transparent, meaning we can remove the wax-up and see what's under it, and we can know exactly what's the thickness of the wax-up. This is a main limitation of the normal analog wax up, where you send the case to the lab and the lab basically adds on wax or removes stone and adds wax, and you don't know how much did he add and you don't know how much did he remove to start with. And that's the beauty of the digital workflow. We can also use virtual articulators. We can actually design occlusion from the get-go, from before you even start. We can know if you have proper eccentric, proper canine guidance or protrusive movements, still without even starting the case. So you know if you have control over the case or not. And you notice here on the lateral, I am actually putting the wax on transparent mode, so I'm going more and more transparent, and I can see how much did the technician add on the incisal edge, so I know how my prep is going to look like, and I know if I'm going to remove a little bit more from the incisal edge or not. And you notice on the canine from the side view, you notice that the canine is overlapping on the gingival margin as per the design, and I know for a fact that on the canine I need to remove a little bit of soft tissue, so I'm going to do a little bit of gingivectomy, a little bit of osseous surgery, whatever is needed. But that is not very easy if I don't have this option. And there's a very nice option too, and I can do a cross section of the wax. I can see the actual thickness of the wax that is added. This is also a very unique option of the digital waxer. After we have designed the case and we tried the case and we tried the mock-up and the patient is approved, then we move on to the restorative phase. And that's when we prep the case. That's when we make our final impressions, and we can design our future restorations. What I find very unique about this digital workflow is I can export the design. Basically, when you do your wax-up and you produce the mock-up, you have an STL file. In this STL file, if the patient approves the temporary and approves the mock-up, you can take the same STL file and export it to the final restorative phase. Meaning the patient will have the final product to be an exact replica of the design phase. And that's what is very unique about the digital workflow, and that's where I find the main problems with technicians and the main problem with dentists suffering from having really nice temporaries, really nice mock-ups, but still the final is different. So you notice here, I prepped the case and I made an impression, a digital impression of it, and I'm going to take the same STL file and put it on my preps. And you notice here the technician will add now the wax. You'll see it in a second. He will add actually the design. I use another set of photos for the restorative phase, where we actually take a retracted view of the prep teeth. Okay, so you notice here the teeth are prepped. I take the photo, I send it over, and he's going to basically put the same design and overlay it on the teeth and connect the margins. Once the margins are connected, then that's it. You're done. So you notice here, those are the set of veneers. Now he's going to export it, and they're going to go into the manufacturing part. They're going to go into the milling strategy part, and where we mill them afterwards. So I find this to be a very unique option, a very unique feature of the digital workflow. And then we mill those units. In this case, we've used so many products, we've used so many materials, and we have some limitations, I have to admit. We have limitations when it comes to thicknesses and so on. And in these cases, we've milled Emax lithium disilicate. And you can notice here the technician is just shaping a little bit, just wheeling them down, and then he's just staining the surface and polishing, and that's it. There's no ceramics whatsoever that is added to these units. They look stunning. They look beautiful. We can camouflage the incisal edge. We can use some lower value stains that basically like the blue or the gray or the violet, where it can bring down the value and they look as if that they are layered, but they are not actually. So these are the units on the model. And I will be speaking very soon about whether we make impressions or what are the problems of making impressions or printing models or actually making gypsum models in a little bit. The lowers also, we always do the lowers with the same material. We do the lowers without any ceramics whatsoever. It's just stain and glaze. It's the same material as the top, but we're just going to stain and glaze them and polish and then deliver. Now, another example of the designing phase of what we do, and that's for some dentists that want to have more control over their cases. And that's still in the designing phase. So in this case, the patient doesn't like really the laterals and the centrals. Now, some dentists want to have even more control and design the case by themselves. And I have absolutely no objection to that. And a lot of times I don't want the technician to design it. I want to design it myself. So what I do is I draw my lines on the photo, on the JPEG photo, and I say, you know, I want the central to be here. And then I take this JPEG photo. You can do the design on a Keynote, or you can do it on a PowerPoint, or you can do it even on a piece of paper. It really doesn't matter, as long as you know where you're heading and you know where you want the incisive edges to be. In this fast forward video, you'll notice that I'm making the design. I'm putting where I want the centrals to be in the laterals, and I'm going to export this as a photo, as a JPEG photo, and I'm going to send it to the technician. And I told him, please follow my drawings exactly. Now, the technician will take this photo and he will put it and import it into his software. And we talked about the photo protocol, a very strict photo protocol, the 2 photos. And you notice here the technician takes the model, takes the gypsum model. Okay, he's viewing it now, and he's going to put my photo that I sent, the photo that I sent with the drawings, and he's going to put the design of the teeth following exactly my frame. So in this case, the dentist has a very good control over the case. He knows exactly where the technician must add or must subtract. Right? So you don't want, because a lot of times you want to control the case. You want to design it. It's like you are almost waxing the case. And you send it to the technician follows your lines, and then afterwards they produce for you the mock-up or the digital virtual wax-up. Afterwards, we just make a simple putty of it and we do our smile test wrap. And we test it on the patient's face. We see, does it look good? Does it need any modification or not? That we need to add or subtract anything else? And I can take the same exact design once the patient approves it, once I prep the teeth and I move to the restorative phase and use the same exact design, just change of materials. You notice here how I'm taking the photos. I always take the photos straight and perpendicular to the patient's face or perpendicular to the patient's nose or teeth. Even for more complex cases, we can overlay the smile with the model, with our drawings of the design, and I can put all of this on top of the CT scan, on top of bone, and I will know exactly where the bone is in relation to the teeth and in relation to my design. And in this case, you notice that the case is a complicated case. Patient is complaining of a very gummy smile and protruded maxilla. I did my design, my 2-dimensional design. I sent it to the lab. The lab is going to copy my design. Okay, and notice here that this is just a the three-dimensional design. He's going to copy my design and put it on in the virtual world, wax up the case, and then he's going to overlap the bone. The bone will be overlapped, and I can see exactly where is my final teeth, my final prosthetic product in relation to the implants or the bone. So I have full control over the case before I even start. And this is the beauty. This is the beauty of the designing phase, or the digital workflow. Notice here we placed 5 to 6 implants, and I know where the bone is, where the implant is, and I know if it's 3 millimeters from my prosthetic margin, and so on. And then we move on, and we print our mock-up, and we print our surgical guides. The next step, the product of the surgical phase, of the designing phase, is always printed models. Most of the time, we print mock-ups, we print surgical guides, we print temporaries for immediate load, and in this case, we moved on to the final. Something else I want to talk to you about is the materials. And when it comes to materials on the digital workflow, I truly believe that we've been doing less and less ceramics lately, and with the digital workflow, it doesn't make any sense that you do all of this work and still layer ceramics. So the whole point of doing the digital workflow is to minimize ceramic layering, and the evolution of ceramic materials is quite significant. That quite a bit of time we don't really need to layer. There are very specific times and scenarios where we need to layer, and I will go into that very soon. But most of the time, with a lot of these rehabs, there is no point of layering ceramics. They actually add weakness to the case when we layer. So such cases where the patient complains of wear, and the patient basically has already eroded or worn at least 30% to 40% of his teeth. He went through enamel. You notice he's complaining of the palatal side, that he's got severe sensitivity. You notice here on the palatal side of the anteriors, he's got all dentin exposure. Quite something that I find
Mississippi.
very important.
Mississippi. Mississippi.
Mississippi is Veneer.
فلافل. فاطمة. Mississippi. Perfect.
And if you notice in this video, when I asked the patient to say Mississippi or any word with any letter or word with the letter F, to see where the central incisors are in relation to the lips, or where the central incisors are in relation to the lower central incisors. And the S and the F sounds are very important, and I need to increase the incisal edge in this case. So if I need to increase the incisal edge, I need to know how much I am doing it, and that's why knowing how much is important, and trying and doing the smile test drive is also very, very critical. So we do our design, and we basically make our design, adding the incisal edges, making them longer, about almost 2 millimeters. Notice here my design is almost done. I send it to the technician, and I write for him how much I need to add, and he's going to wax up the case. The case is being waxed up, and I take it to the patient, and I do my smile test drive, and I test it. I see, is it really reasonable what I'm doing? Does it really show more teeth like he's asking for? Does it make him look younger? And in fact, it did. Patient likes it very much, and then we're going to move on. And since we are adding incisal edge length, we need to open the vertical dimension most of the time, especially in this case where the palatal side is worn, and I need to control occlusion. I need to control my protrusive movements. So the 6 anteriors will be crowned, the posteriors will be veneer onlays. We're going to do very minimal preps on the posteriors, but on the anteriors, I have to prep them into crowns. I cannot do just veneers because the palatal side is already worn down. So we open the vertical dimension, we do our preps. With a lot of these cases, with a lot of these full arches, I still prefer to make physical impressions. I honestly don't see intraoral scanning on these large cases to be very helpful. This is my take for 2017 December. I can't say that this will be the same maybe next year or the year after. But as for now, I can tell you for a fact that making impressions on these large cases is a lot more precise, a lot more easy. It's easier to handle. It's faster, in fact, than taking intraoral scans. So as for the materials, when it comes to the workflow, we always prefer to use monolithic, no layering whatsoever. And in these cases, I prefer the medium translucency ingots. That's where you can get really nice value of them, good strength, and at the same time, they look translucent to some extent. So these are the definitive units. Here you notice I'm placing them in the mouth. They look very reasonable. They fit his age. This is the maxilla, and you notice here that the fit, I think the fit in the next video is exquisite with these milled EMAX restorations. The fit on the margins, using of course our gypsum models as the main control model. The fit is exquisite. And you notice here there's absolutely no layering on those teeth whatsoever. First of all, it's much easier to control the case when we design it on the computer and mill them, and then we just fit them on the model, make them look nice with stains and glaze. And also they are stronger. The weakest link in our restorations is the ceramics. That's the weakest link. That's where things fail at first. You've got chipping of the central incisors, and most of the time the chipping happens on a Thursday or a Friday night, right? And that's why it becomes very, very annoying, and redos are just unreasonable at this stage. On the mandible we did veneers because we opened the vertical dimension. We didn't need to do any crowns. We have full control over occlusion, and this is how it looks after we increase the incisal edge, have full control over protrusive movements, eccentric canine guidance, and we have achieved full coverage, no sensitivity, phonetics is better, aesthetics is better, and for longevity, the patient will really not have. I've been seeing it now for 5 years almost, and there's absolutely no chipping on those cases, although he's a heavy.
It's good. 66 Mississippi.
Notice how the F sound is getting better.
Fatima. Church. Mississippi. Good. اعطيني ابتسامة عريضة.
So controlling the final control with the phonetics, I think, is very important with the S and the F sound. Also, a lot of times we ask the patients to say anything with the letter or with the CH, so church, because when you say church, you actually show teeth, and we see how much teeth are we showing on display while talking, and the patient was extremely happy. And again, the main point of this is using monolithic materials. Why do we use monolithic? You have to understand also that the substrate, what's underlying these units, is good colored dentin, and that's where we see our main playground for monolithic, is when we have good substrates under those teeth, good colored substrate. We don't have any discolored teeth. On this case, you notice that the patient is complaining of the centrals, got several composites. The laterals are small. He wants to change his smile, and there's several composites on the teeth. We're going to remove it. And you notice here on the left side, I've prepped teeth. On the right side, they're still not prepped, and the amount of prepping is extremely minimal. And that's also another advantage of using monolithic materials, that we can go extremely thin with those materials. We've done so many trials on those materials, and we realized that we can go with milling, with designing on the digital machines and then milling them. We can go up to 0.3, and in very, very rare situations where the prep is extremely smooth, we can go up to 0.2. So we're talking about 0.3 millimeter on average thickness of those ceramic veneers, which is also which makes the case, which makes you even less aggressive, and you don't have to really prep as much teeth, and you're staying on enamel. So better longevity and no layering whatsoever. This case is all done with stain and glaze and polish. So I just wanted to stress on the fact that we can go very thin with monolithic materials. The moment when you start to layer, then you need more and more space. Now, that's everything I said was the good side of the digital workflow. But we've got really the darker side of it, which is a lot of times we have good colored and discolored substrates. And that's where we have to modify our technique. And that's, I think, where the digital workflow becomes interrupted. The moment we have dark substrates, we have to start modifying our prep designs and modifying and being a little bit more aggressive and changing our finish lines and going a little bit more deeper and more aggressive, more thicker. So you notice here, we've got the canine, the lateral, and the central are veneers. One central is a crown, and then you've got natural teeth on the other side. So we've got very good colored substrates on 3 of the teeth, a very dark substrate on the central, and then natural teeth. This is extremely difficult. Here, with these cases, I find digital workflow to be interrupted, and that's where we cannot move forward with that. And that's where the human artistic element must come in and try to make or mask the discolored substrate and make it look vital and translucent or transparent. In some cases, I mean, lifelike. So we've got on a dark substrate, we've got at least 1 to 1.2 millimeter thickness. But on a very good color substrate, we can go up to 0.4 or 0.3 millimeter thickness. Gingival margins. Your margins must be sub-gingival when you are on a dark substrate. You have to go at least 0.5 to 1 millimeter sub-G, but on a good color substrate, we can stay equigingival or supragingival. That makes even scanning more difficult. So again, digital workflow becomes a little more hard to make because you need to push those tissues out and to be able to scan it, and that's where impressions become easier. So everything, when we talk about dark and good color, it becomes a lot more harder to do. And the case is done here, we've done it all by hand. This is all done manual. Another case where we have also a dark discolored substrate and a light colored substrates. From our own trials, we realized that anytime your ND, your natural dye stump shade, is more than 5, and this is just very anecdotal, this is from our own trials in the lab and in the clinic, we noticed that anytime it's above ND5, your prep must be 1 millimeter at least thickness. Anything that is 1 or 2 or 3 or 4 ND, you're good to go with 0.5 or 0.6 millimeter thickness. So this is something that is an objective way to look at your prep designs and your aggressiveness, or your conservative, if you're conservative or aggressive in those cases. In this case, we prepped the case, and these are the temps. I have a very specific way to make temporaries chairside, where we actually control everything, the margins and so on. Here the patient goes home with the temps, And then we do our final. Here, we have to layer. We have to have gypsum models. We have to layer ceramics, and we have to be artistic. And that's where your technician must have an artistic touch to know how to mask those discolored substrates. You notice how subgingival I am on this central incisor. This is a try-in day. This is after 2 weeks, and this is after, I think, maybe a month or two. And on the patient's face, if you have a close-up, it looks really nice and really vital, and you cannot tell that this tooth is actually almost brownish, what's under it. So going to a little bit more aggressive, or a little more difficult cases, the patient comes in here with a dark central incisor, and we removed it, and you notice how dark the stump shade is. It's brownish, it's chocolate color, it's very, very dark. It's darker than ND9. This is very hard. And I'm going to share with you a small video of my prep and how I am actually prepping. And with those dark teeth, I have to prep and go deeper. I've mentioned before, anything above ND5, you're talking about 1 millimeter at least to 1.2. Here we're talking about a tooth that is ND9 or more, so I need at least 1.2 to 1.4 millimeter thickness to be able to mask but still layer ceramics that makes it look really nice and translucent. So we do our prep, we place our first cord, and then we move on, and I'm going to put a very thin veneer on the central and the laterals. And then I move on to the next tooth, and I'm going to prep. Now the centrals and the central and the two laterals are good colors. So my prep is extremely minimal. I'm prepping 0.3 millimeter to 0.4 at max. I don't need to go deeper on the central, on the veneers, because they're good colors, and I know I'm going to use something that is very translucent. I'm going to use a very translucent ceramic material. I'm polishing here the margins. I use the white Arkansas. I polish the margins to remove any J margins, any lipping in those margins. In this case, we have done a trial where we did an impression, and we're going to scan and another impression. So we're going to try to use the digital workflow and the analog workflow and see which actually works better. We're trying to push the envelope as much as we can with digital and see, can we really do this case fully digital without the need for layering. And just not to let you wait for the answer, my answer is, unfortunately, it's not doable with these cases. It's just not doable not to layer. We've tried, but it just doesn't work. You have to layer, and you have to interrupt this digital workflow, and it becomes manual, and it becomes the normal, old school, traditional workflow. Notice here my prep on the central is extremely minimal. I'm almost done here with the central. I'm just modifying the margins. Place the cord, and then I'm going to put my second cord, and my second cord is to push everything horizontally. A little take here on intraoral scanning is, especially between two veneers, you notice that between the two veneers, between the two finish lines of the two ceramic veneers, we have noticed that it's very difficult to see the margins with intraoral scans if you have two veneers that are close to each other. It's just easier to make impressions. It's much more visible with impressions, normal impressions, and stone models. Again, this is just the reality of it. So here I'm placing my second cord on the dark substrate. I might go a couple of times around it because it's very subgingival, and I need to push those tissues horizontally. So at this point, I am ready to make the impression. I remove the second cord. You notice I'm removing it very gently. My margins are fully exposed. It's a very stress-free procedure where I know exactly that my margins are exposed and my impression is going to be successful. I place my light body into the sulcus, making sure that the tip is always touching the margin. While I'm placing the light body on the teeth, my assistant is placing the heavy body on the tray. I take the tray and I'm going to press it and make sure that I have an impress of the teeth. You notice here we have a successful impression. The next step will be to take an intraoral scan, and we actually took an intraoral scan with a Trios camera. Here, this is a fast-forward scan because with intraoral scans, it's slow. It takes time. I mean, and I can say that I've been using it now for multiple years, and I'm pretty confident with it. But still, it takes more time with me than it takes with a physical impression. Everything I am saying is from my real experience, from my real day-to-day dentistry that I see every single day. And for me, a physical impression takes at least 30% less time. So this is the final product. You've got to see how the ND is extremely dark. And again, we do the same thing with the digital workflow. We overlap temporaries on the software. We put our temporary and then we overlap it on the model. So we have full control of the incisal edge and knowing exactly where we're heading. This is a small video of showing you how the technician here is designing the case, and he's going to make 2 sets of materials. We're testing here if we can do full digital or not. So we're going to do 1 set of veneers on the veneers, and on the dark central, we're going to try to do a set where we don't layer, and another set where we have to layer. Okay, so we wanted to see if we can really do it fully monolithic and fully digital. So we're going to do, as I said, 2 sets. This is a print model. The first set is going to be the double veneer crown, where we have 3 veneers, and then we have on the dark tooth, we're going to have a medium opacity crown that looks like a veneer being prepped. And then on top of it, we'll have another veneer. On the second option, we'll have a coping. We'll have 3 veneers, and then a coping that looks like a zirconia coping, and then on top of it, a crown that is from the same translucency as the veneers. So this is the double veneer crown, and medium opacity crown that looks like a veneer being prepped, and then on top of it another veneer. And in this case, we're gonna not layer at all and see if the medium opacity can mask, and then the veneer on top of it will give it this nice look. On the second option, we're gonna have a crown, a coping, a zirconia crown, an opaque zirconia that is gonna mask, and then on top of it, an Emax crown that we're going to layer. So you notice here, there's a double crown, a zirconia, and then an Emax. So we did our first one where we didn't layer, and the second one where we layered, and we noticed that we got the best match with the zirconia coping that is fitted on the tooth, and then another crown on top of it. So a double crown option with layering of the crown to make it mask or match the veneers beside it. This is what we find to be the best result. You notice on the polarized, you've got really close looking, they're very close to each other, the veneer and the crown, although the crown is extremely dark, it's almost black. Okay, so you notice here there are 2 layers, you've got veneers on the side, and then you have a coping that is made out of zirconia, and then another crown that is made out of Emax from the same material. This is the same day of the delivery. This is how it looks on the smile. I think we got a decent result, something that looks very, very close to his natural teeth, and the patient was very, very happy with the result because he's been suffering all of his life with this dark central incisor. So done with the teeth part, and I hope I gave you the juice of what I think about teeth and the digital workflow. Now, when it comes to implants, it's another game. It's another way to think about it, and I'll share with you my take on it. We always prefer to go screw retained on implants. We always prefer to do that. We don't do any cement retained. I have to say that my cement retained is extremely minimal. I prefer it for many, many reasons, and I don't think I have the time to talk about it now, but there's just no comparison. So 3D implant position, everyone who places implants will know that implants must be placed in 3 dimensions. The mesiodistal part, the buccolingual, and the apicocoronal. I'll be concentrating on the buccolingual dimension, and that's where I think that made a huge difference in the way I practice. The buccolingual dimension. Anatomically, we know that the maxilla resorbs apicocoronally. We all know that, and that's how humans are. Our maxilla resorbs like a cone. The maxilla gets smaller with age as we extract teeth. So what I did, I took a tooth from a gypsum model, and I sectioned it right in the middle, and I wanted to show you just a little diagram of where we are. The tooth, the bone, the soft tissue. So I drew where an ideal bone looks like and related in relation to the tooth, and I placed an implant. And this is an ideal place for an implant. It's fully encircled with bone, ideal. This is a cement retained position. The trajectory is going through the incisal edge. We basically place the implant in a screw retained position. This is a screw retained position that is coming through the cingulum of the central incisor. This is an ideal bone, the white line. If we have a compromised bone, that's where we extract the tooth. It's been a few years, the bone has resorbed, it shrunk. This is a compromised situation. If I want to place the implant in a compromised situation, and we see this on CT scans all the time, we've seen it. I see it on a daily basis. If I want to place the implant within bone, then my position is in a screw retained position. Sorry, in a cement retained position, because I'm following the bony architecture. If I want to place the implant in a screw retained position on a compromised bone, then I'm definitely having a problem. I'm going to have fenestration. So placing the implant in a screw retained position on those compromised situations is almost impossible. Now, this is the biologic position of this implant. This is where the implant must be, but it's not a screw retained position. For me as a prosthodontist, I want it to be in that position. I want it to be screw retained, but I can't. So thinking out of the box and trying to see, can I really place the implant in a biologic position, but still having it screw retained? And this is basically a concept that comes from engineers, and it's been out there for a long, long time. And we basically use screws that look like balls, right? The screw look like a ball head, and you can place the screw and torque the screw on a 30-degree angle. And you notice here from this video on a central incisor, I place the implant, and the implant is coming through the incisal edge. It's a perfect cement retained position, but still with the digital era and putting it on the computer, I can still push this exit to come through the cingulum. And this is where I find the digital workflow to be amazing with implants, because I can control all of this digitally, and I can push the screw channel to come from the cingulum or from the palatal part and design my future restorations and know what's the thickness and how much I have before I even mill anything. This is the true advantage of the digital workflow when it comes to implants. And again, I place 1,500 implants a year. We place so many implants, we restore a lot of implants 98% of those are screw retained restorations. So you can see here how I'm tilting the screw axis to come palatally. Okay. This is a short video of a case where the central incisor, the axis is coming incisally, but I can still push it. This is from the same video that I showed you before. The design, we milled this zirconia, we put it on the tie base, we cement it on the tie base, and you notice here I'm putting the crown with the tie base on the model, and I can still screw retain it from the palatal side, although the axis is coming through the incisal edge. The nice thing about it that you only have one screw, one abutment, and you can screw it up to like 30 or 35 Newton centimeter. This is the case, this is the actual clinical case, and this is it on with the X-ray. Notice there's one screw, one abutment, and this is the final. So when it comes to full mouth rehabilitations with implants, we noticed with the digital workflow, we can push the envelope, we can make everything more screw retained, and we can have minimal controlled cutbacks. Basically, no layering or minimizing the layering, or even on full mouth rehabilitations where it's very complex and very large. So with these cases where we have full maxilla implants, 6 implants placed, I can take that case and I can digitalize it. I can put it on the computer in the software and start to design my final teeth. And with this option that I can push the screw axis palatally, and then I can make those teeth cut back, and I can cut them back 0.5 to 0.8 millimeter thickness. Only the amount that is needed to layer. Imagine as if like you are layering veneers on top of them. Extremely thin, just to give it this nice lifelike look. Everything on the functional side is on zirconia. There is no ceramics on the functional side, on occlusion, on palatal. Everything is zirconia, except the facial side. This was when we started like about 2 to 3 years ago. We started doing that, and then we realized that we can go even further, and we started to push the envelope more and more. This is a zirconia structure that is fully made out of zirconia, and just to show you here, this is how it looks pre-sintered. We take it out, we put it in the machine, we sinter it fully, and then the technician starts to layer. And we only do 2 layering. The first one, the second one, and then the glaze. So there's less stresses on the ceramics. Extremely minimal layering of ceramics. Minimal stresses. Good aesthetics, and very functional. So you notice here how the implants are coming facially, but we still can do it, or we can still manage to get it to be screw retained. The beauty of screw retained is I can deliver these cases within, I can say, 15 minutes or 20 minutes, and I'll be done with these cases. Imagine if there is cement here. I probably need a couple of hours to finish the case, and I still don't clean cement properly. And that's why I think screw retained is extremely useful. This is the final case. There's with the patient's face, and it's a great transformation. Just the patient, we've changed this patient's life. Another scenario where patient is complaining of dentures, removable dentures, and there are many teeth that are infected, remaining roots, and we're basically trying to give him something that is fixed. Many infections in the mouth, we're going to extract everything, place implants, and immediately load. In 99% of those cases, we extract and we level the bone and we load, we place implants and load at the same day. Patient comes in at around 10 o'clock in the morning or 9:30, and he's out by 2 o'clock. with full set of teeth. We tried here the teeth to see how it looks. See the patient likes this, the teeth setup, and then notice here we're talking also, we're trying to see if phonetics is good, always controlling with phonetics. And then we move on to the surgery. We're going to extract teeth, level the bone, and then place implants and use the same surgical guide to pick up those cylinders and immediately load the case. All done within maximum of 5 hours. So a patient comes in at 9 or 10 and leaves by 2 or 3 maximum with fully functional, screw-retained restorations that are just, they look good and they're stable, and you don't have to see them for the next 3 months. I use flowable composite to pick up, take it out to the lab, finish it, polish it, and then deliver. And you notice for the definitive restoration, we do the same thing here. I'm going to use in my restorative execution part, I'm going to use my immediate load prostheses to help me with the design. I take a certain set of photos and I use this immediate load prostheses, and I know exactly, I have a very fixed reference point, and I move my teeth and I design, I make my cut back about 0.5 to 0.8 millimeter, and then we move our axis and then we mill. Notice here there's the milled zirconia. We always prefer with these cases to mill semi-translucent zirconia. It's not fully translucent, and it's not opaque. It's a semi-translucent zirconia. It gives good aesthetics and it has good physical properties. We only need to do two bakes. So the first layering is basically the technician puts the first bulk of the teeth, puts the effects, puts it in the oven, takes it out, does the final touch-ups, layering, and then stain and glaze. So you notice here that we can control aesthetics very well because we have a very thin layer of ceramics. And then the delivery is extremely easy. This case I delivered probably in less than 10 minutes. It's just 4 sets of screws. We unscrew, we screw in. Occlusion is on, and then the patient goes home. We just close the access holes. So this allowed, the digital workflow with implants allowed me to make my delivery easier and my maintenance even better. And patients have restorations that last for a long time with the least maintenance ever. This is the final restoration. Zirconia, screw retained, and 4 implants. Implants are all within bone. Notice we have 4 access holes, and this is the final. Now we have pushed the envelope. I still probably have 10 minutes to show you. We've pushed the envelope even further, and that's recently being done, probably the last 2 years, where we are not layering ceramics at all with these cases. 0 ceramic layering. That's because we noticed that we have good control. In this case, there's 0 layering of ceramics. Absolutely no. It's just absolutely no layering. It's just glaze, polish, and stain and glaze and polish. Because we noticed that we can control shape very well with the software, and the milling machines are becoming better and better. And we have really nice digital libraries. So there's no point of layering with these cases. This is another full restoration where we only layer the pink. The teeth are not layered. And again, with those abutments, I can make everything pushed in and screw retained. So the digital workflow of implants allowed me to deliver cases much faster, to make them more predictable, to minimize layering and minimize chipping and maintenance with these cases. Another case where the patient is fully edentulous with rampant caries on the lower. He's got a denture, and we same thing, the same scenarios. We place the implants with immediate load. We take our immediate load and we use the immediate load for the restorative phase. It guides us so well. If we're here, upper and lower immediate load prostheses, we put them on the model. I still believe that we have to use physical models with implants. With these restorations, there's no way to do it digital. We have to have a physical model. This is my take so far. Again, it's 2017. My take is no way we can do it without a physical model. So we use the immediate load prostheses. We scan the upper, we scan the lower, we design the upper. You notice here everything is done virtual. This is the final upper restorations. Zirconia being we can design the final, remove the final, put the temporaries, remove the temporaries, put the final back, compare it on the face, move our screw channels inwards, make it screw retained, do the lower again, the same thing. Notice here the lower is also fully edentulous. We're going to use full implants. We're going to do full zirconia on it also. And upper and lower. And that's it. We only layer the pink. The white is just shaped, stained, and glazed. And anyone who looks at x-rays and looks at those x-rays will notice that there's no layering. It's white opaque on the x-rays. It looks strange for us, but this is how zirconia looks like. Okay, this is the same day of the delivery. With those cases, again, the delivery is less than an hour for the upper and lower controlling occlusion. Patient goes home in less than an hour. Semi-translucent zirconia. The final case where we have pushed the envelope so far by trying everything digital, but still we have interrupted the digital workflow. And I'll show you now how we took this case from the design. We designed the case and we manufactured our surgical guides to place the implants with a guided surgical guide, computer made. Place the implants. Notice here we do our digital workflow photos. We took the case, we scanned the model, we took our photo protocol, we designed the case in the designing phase, we overlapped the bone, and we know exactly where the bone is. We placed 7 implants based on the future design. We exported this file and we sent it to the lab to print a surgical guide. The surgical guide is mucosa borne. It's going to fit on the tissues, and then we're going to screw 7 implants through it and place implants and immediately load. I've done this case with the M guide, where they produce for us this surgical guide. It fits on the soft tissue with 3 pins, with 3 lateral pins that go through the bone. We also milled and printed temporary restorations. We milled 2 types to compare. One is without the palate and one with the palate. We went into the surgery day. We placed our implants within probably 40 minutes. We placed 7 implants, flapless, and then we attached our titanium cylinders. Titanium cylinders go through the temporaries. We pick them up with flowable composite. These are the cylinders. This is the temporary. We pick them up through the flowable composite material. We take it to the lab, we layer some pink composite, and then we deliver it to the patient. This probably takes, I would say, in total, maybe less than 2 hours to finish the whole scenario from start to finish. So here, the upper and the lower are implant borne with immediate load prostheses. Now, I'm going to take this immediate load prostheses and use the same the same files that I used before to make my final restoration. However, and that's where I see the drawback, is where we have to make implant level impressions. It must be done physically. This cannot be done digitally, and that's again that's where the digital workflow gets interrupted. So I like to use these trays that I can convert into open trays. I don't use customized trays. We place impression copings in the mouth. We try and make sure that the implants are going through.
Every life we have some trouble. When you worry, you make it double. Don't worry. Be happy. Don't worry. Be happy now.
In this case, I'm going to use bite registration material to make my impressions. I don't use light and heavy body with these cases. I use one impression, which is bite registration. Very solid, very hard. I don't connect the impression copings at all, because this bite registration is extremely hard, that it feels like you have already connected those copings. In the mouth, on the tray, you only have a window of 60 seconds or 40 seconds even max. Wipe it off. You've got the impression coping sticking out. You wait for about a minute or a minute and a half, because that's what it takes for the impression material to set. We unscrew, and that's it. So, yes, it is analog, and it is a normal impression, physical impression, but really it takes less than 10 minutes total. It's very easy to do. It's not hard, and it doesn't take time at all. This is the impression being done, and then we move on to the designing phase, or to the restorative and execution phase, and that's where we are going to make our final teeth. Again, you see here we have a model. We have a physical model that is scanned, and we do the same protocol that we do before. The only difference here is that we are not layering ceramics, and we're going to design teeth that are made fully of zirconia. So we have the photo protocol. We always put the teeth on the patient's face to see if it's good, if it's following the occlusal plane. Once everything is confirmed, we make our access holes going through the palate, screw retained, and then we mill. So we milled both maxilla and the mandible in zirconia, controlling the occlusion. Everything is done virtually, so we control occlusion, the excursive movements on the software, and then we start our layering of only the pink part. The white has no layering at all, and that's it. That's how it looks after it's stained, glazed, and polished. This is after it's being delivered in the mouth, and this is the final. So it's a huge change for the patient, a huge change from start to finish, the least amount of headache, the least amount of maintenance, with no layering at all, and with the most, I think, in my world, this is probably the most predictable digital workflow that I can find so far, and I have tried so many. So I hope that gave you a good, maybe an introduction of how, or maybe a little bit more than an intro about how the digital workflow happens with teeth and implants, and the good stuff and the bad stuff that unfortunately not a lot of people speak about. And for me, as a private practitioner, and someone who owns the practice and that works with patients all the time, I see the good and the bads, and we work around them, and I hope it was helpful. It was a great pleasure to be on this webinar. Thank you for everyone who worked on it. They worked very hard on it, and I hope the message went across. And you guys are more than welcome to come to Abu Dhabi and to visit us at Hikma, to this beautiful city. Bye.